Because we have root here. These are the roots. And after that, there is some product. It's a name.
What I know is that the root is what emerges from the intervertebral.
No. These are the roots. These are the roots. This is the spinal nerve. This is called as spinal nerve. It's not called, because if you see the spinal cord, you can see the rootlets are emerging out. They are not coming as one mass. There are so many filaments which are emerging. So these are the roots. Is it clear? My dear, this is a section. Wait for my second last slide. I have an image for you. Slide number 23. So now, I have one concern here. I'm saying all the spinal nerves also contain sympathetic component. But I'm not showing you here any sympathetic component. Okay, what is this sympathetic is doing for us? Any idea?
It's involuntary control
Of? Fight and flight response. Gentlemen, what you are busy? You are busy with your mobile, so give me the answer. Don't look behind. You are busy. I saw you. No. What's your name? Yusuf. Tell me what is sympathetic. Muhammad has given some answer. Somebody has given some answer. I don't want example. I want what is sympathetic. How it's doing. And where we have the flow. Because you took 2 lectures, I understand.
Yeah.
Muhammad, I'm not asking. I'm asking Yusuf. Sabr. Oh, I'm not saying. I'm saying who are you? You are saying I'm for this. No, I'm not concerned. I'm wearing this. Now I'm asking who are you? Let's say I'm asking what is your nationality, and you are telling me I eat this in the breakfast. So it makes sense.
Part of the autonomic system.
Hello. Yeah. Yeah. Voluntary or involuntary? Involuntary. Very good. So, Muhammad, you had given the answer. Sabr. I have 60 more people in this class, and I want to have an answer from everybody. If I want to teach Muhammad only, I'll take you out and we will learn each other. But now I'm here for everybody. So just give others a chance. I want to involve everybody. I know someone is sleeping lost in the corner. So I have to involve him as well. I want his input as well. So I want to see everybody who's doing what. Okay? So don't mind. I know you have the answer. And your answer is right as well. But the problem is, I am here for everybody. So you are saying, Siri, why are you scratching? Is it so difficult? What we were talking? He can answer. Where is your godfather now? You know, Siri had a godfather also. Gentlemen, you are not answering. You are busy in your this thing. Tell me. I'm reading what? You can read it here. Why are you reading it here?
I can't see.
You can't see. So why don't you see a good ophthalmologist who can make your eyes in a proper functioning? Yes.
It's involved in speeding up the rate of the pulses, so it's called contractions. So the sympathetic nervous system is also speeding.
Okay, fine. So what we have gathered is the sympathetic system is a part of the autonomic nervous system, and this prepares us. Somebody said it very nicely. It prepares us for fight, flight, and fear. So can anybody give me an example of a real life situation where you have a fight, flight, and fear situation? You are raising your hand now. Can you answer me? I don't care. I care for real life. Nobody sees where. Muhammad, sabr.
I didn't say anything.
You raised this. Osama ran away. Fine. Khalas. Osama is gone with his long tower. Osama is disappearing. He's maybe. Listen to Najmuddin. He's giving you wise advice. I respect. I like you. You know a lot. You know more than you. See, let others make an effort. Because I like that this whole class will go in year 2 with good grades.
Hopefully, yes.
Inshallah. I'm working for that. My objective is everybody should be the best. Inshallah. Okay, guys? So, give me a real life example. Look, it's very easy example.
During a fist fight, for example.
You doing what?
Fist fight.
Fist fight.
Yes.
What happened? What is excitement in there? What is fight, flight and fear? Think of fight, flight and fear. Yes.
When a wild dog trying to catch you.
Yeah, that's good. Good example.
Doing exercise.
No, man, it's not. Sorry. There is no excitement. There is no fight. There is no fear. And is there any fear in exercise? Fi khawf? Fi khawf?
Like when you are crossing the intersection on the Ishar.
Yeah, get green and you can see, ooh, this big truck is coming. Yeah, very good. This is something, yes.
Robbery. Yeah, homeless.
Someone is breaking the lock and oh man. Okay, so when you drop your phone and his iPhone 10 maybe, and you are riding a boat and you are going in a Red Sea in Jeddah, and you can see your iPhone 10 is disappearing. Some fish is calling hello. Yes.
Giving a presentation for the first time.
Yeah, that's very true. Now, Mohammed, you can talk. Finally.
When somebody falls off a cliff.
Yeah. So I can give you another example, which is matching to all this. Say you are busy here, you are working very nicely. Now you are leaving uni after around 6 o'clock. Everybody is gone. You get out of the gate, any gate. Now outside we have big palaces around our uni. So somebody may have, I know someone, have a lion, Asad, in their home. And for accident purpose, he may get out of his cage and he just walked out and you see him standing just in front of you, looking at you and just staring at you. How you'll feel? This is the time where you have, here you have all the sympathetic. All the sympathetic. Because you're going to know he'll eat you like a popcorn. So, your all the sphincters are tight, you're sweaty, your hairs will stand, you cannot shout, your mouth becomes dry, and you have wide open eyes, you cannot run, you're just in a fix, you're just in a state. That is sympathetic. Okay, what is parasympathetic?
Parasympathetic when somebody is eating. Rest and
Wow. So food area, everybody is parasympathetic. Now give an example where people should not forget it. Yes. I can fine. I think so. There is 2 more discussion on that. Let me zip it up. Okay, you have gone for you work hard for your exam. You did very nice. A group of the whole class will decide. Yes, batteries. So the whole class decide to go for a cruise. And you are, in some place where you are enjoying and, enjoying your istiraha or some other place. And suddenly, like, you are doing something which is lawful and something which is non-lawful. And Haya force comes there. What happens then? You know Haya? Haya? So what happens then? Everybody is now, the whole parasympathetic is gone. Food, enjoy, music, all is gone. Now you are in trouble. Got it? Okay, they will tell you.
There's nothing wrong with Haya.
Sabr, I will talk to you outside. Is it clear with everybody? Now, this is where I have the cell bodies. This is where we have the cell bodies for my sympathetics. And this sympathetic, Muhammad, now there is a question for you. Now this question will begin with this statement. Sympathetic neuron we have only from T1 to L2. And we say here, all spinal nerves also contain sympathetic component. It means all 31 on right and left. How it is happening? No, you are not Muhammad. This question is for Muhammad.
Yes.
Muhammad says, I'm very excited, I know more than everybody, so yalla.
No, I didn't say that.
Okay, prove it then.
I did not say that.
Okay. Huh? My question is, I say sympathetic neuron from T1 to L2, and I'm saying here all the spinal nerves also contain sympathetic component, but it says only from T1 to L2, and I have 31 pairs, not less. This is too less. So how this sympathetic is reaching to my other areas?
So the rest will be in branches and not in the gray matter. They will be in branches with the cluster of the other motor and sensory.
No.
The sympathetic trunk, basically. Yeah, using the gray ramus communication, you can go up.
Can you elaborate? You are very close. Trust me, you are very close.
The sympathetic trunk is run parallel.
Guys, listen to him. He has a very good answer. As long let's see he can make it or not.
Okay, the sympathetic trunk run parallel to the.
Okay, guys, do you know what is sympathetic trunk?
Yes,
What is that?
which is introductory.
With on the sides of the vertebral column. And now,
From the spinal nerve, from each spinal nerve, there is a merging of white and gray ramus communicating with the sympathetic.
my dear, you can use it's in front of you. It's in front of you. Look, this is the sympathetic ganglion, and you are looking at gray and white rami committents. Now, by saying this T1 to L2 means only we have cell bodies present in this level. Upper level and lower level we don't have any cell body. Now, these sympathetic fibers, they traverse upward and downward, and they have been utilized, so every nerve have, but we don't have these two in every nerve. They are present in only specific places, and these places are from T1 to L2. Now this explanation may be not enough for you at this level. You might have a little bit frustration. So this explanation I'll be doing with you in more details when you'll be coming after your semester break, in cardiopulmonary block. There I have a lecture on this material, and this is where you'll be learning all about. Is it clear? So that will be explained at that part, but simply what he has answered, just remember that this is a continuous chain, so the fibers are running and they are going with everywhere. So like you can see that this sympathetic fiber cannot come directly, it relays in this ganglion, and this is sympathetic ganglion. And then this is the postganglionic fibers, and now each spinal nerve, all 31 pairs of spinal nerve have a motor component, have a sensory component, and have a sympathetic component. Now my question is, why we need sympathetic for each spinal nerve? This is my next question. Yusuf.
So we can have it needs to be equal.
Before you are answering this question, without knowing what you are saying, Uday.
What needs sympathetic?
Yes, everywhere. Talal. Yes.
We need the sympathetic because
Say loud. I want everybody to listen to you.
knowing we need the sympathetic because the fight and flight process is the only way for it to happen.
So we can have a fast way for the stasis to use.
Yes. Yeah. You don't know. Umar. Umar Aswad. Any idea? Mohammed, I can see your hand. Everybody is visible to me. Relax. Bring it down. Huh. Can you answer now?
Responses. The sympathetic fibers are everywhere because the skeletal muscles are everywhere.
So, are they doing something with the skeletal muscle?
No, I mean it's like for the dilation of blood vessels. It's for so that blood will go.
You're answering other part right, but you're missing one very important link. Yes.
Some of them will not work, the others will.
What Muhammad has started, he has the right answer, but he needs to rephrase it. We have smooth muscles also, everywhere, in the skin, in the blood vessels. with the erector pili muscles are there, which we have so many sweat glands. So everywhere, like when it's hot, you are sweating from everywhere. Got it? So who controls this? The sympathetic and parasympathetics are coming in play, and primarily we need sympathetic. So blood vessels, you had a cut, there's a bleeding, you press on it, it stops because it goes in vasoconstriction. Who causes vasoconstriction? Because the make of all my vessels is by smooth muscle, and these smooth muscles are controlled by sympathetic. So for supply all those minor capillary level, we need sympathetic innervation everywhere. So it traverses with each spinal nerve. That's why is needed. Understand? You are answering other half right, but you are not having, you are saying skeletal muscle. If you could have used the word smooth muscle, your answer was perfect. Is it clear to everybody? We have learned something about what a spinal nerve is, how it is being made up of, and what are the basic ingredients for having a spinal nerve is. It should have motor, sensory and sympathetic. Clear? Going further. Now I'm making a plexus. I'm in a process of making a plexus. For making a plexus, I need more than one spinal nerve. One nerve cannot make a plexus. Why we need a plexus, guys? Gentlemen, you didn't answer anything today. Today you are quiet. I like you speaking. Yeah, I want you to give me the answer. Why we need plexus in our body? What is the purpose of having a plexus? Hold on, I'm coming to you guys. Because before he was actively participating, so I'm really worried why he's not answering today. You're listening, good, but I want you to answer now. Gentlemen, do you think some answer? Yes.
To share root values because we don't have enough.
Dermatomes, different
Yeah, me.
Contribution from different roots, so if one of the roots is damaged, the other one's.
Yeah, makes sense. So we need a plexus. We need a plexus. We have so many muscles in our upper limb, a big number. And if one nerve is cut, that part is gone forever. But we had too much crossover. Too much crossover. Because spinal nerves, they blend, they become one. Then they divide, then they join, then they divide, then they join. So they make complex nerves. And these nerves carry different type of fibers. That's why we put, you can see it's written C5 to T1. Some nerve says like this. Some nerve says T8, T1. Some nerve says 5, 6, 7. So we had contribution from everything. And for that reason, our spinal cord shows two swellings. One is cervical swelling and one is lumbar swelling. Cervical swelling gives us a cervical plexus and a brachial plexus. And lumbar swelling gives us a lumbar plexus and the sacral plexus. Lumbar and sacral plexus will be of our use when we will be doing the lower extremity. And the brachial plexus is useful when we are doing the upper extremity. And cervical plexus is useful when you will be doing your head and neck. Year 2. So now I have C5 and C6. We have these roots, dorsal and ventral roots. This is my spinal nerve. This is my spinal nerve. Now this place, they emerge out of the intervertebral foramina. Now they become the anterior and posterior rami. Now we not call them roots. Here we call them roots. Here we call them rami. Here they are rami. So let's build on that. Is it clear so far? And all the plexus have been formed by the union of ventral rami, not by dorsal rami. Dorsal rami, it contains everything, but they are designed to supply the muscle and the skin of the back. And ventral rami are designed to supply muscle and skin of the front. And they blend, they make these plexuses. This is my nerve trunk. So there are different levels. We'll be learning in our next slide why this, at one place we call it root, then we call it a trunk, and then we'll call it division, then we'll call it cord, then we'll call it a nerve. So these are different levels of formation of the plexus. Is it clear? So now two nerves, the ventral rami, they are participating and they are making a nerve trunk. You want to say something, gentlemen?
Yeah, you said that roots only making the
Plexus.
Yeah. So why isn't ventral and dorsal?
Dorsal is not participating in any of the plexus. That's it. That's the rule. Okay? So now, so each nerve trunk divides into anterior and posterior. Right? Huh?
What is the word non-segmental?
Oh, I need at least 2 hours to explain this word. You have that much time? If you have that much time, I'm ready to explain it.
No, but like
Segmental and non-segmental is a very big detailed discussion where people need to learn it. On an appropriate time, I'll explain it to you.
Was it explained before?
Never. I explained last year, and then after wasting 1 hour of their and mine, there was no use, there was no fruit. So then I decided I will explain it when you have little more, you will be grown up little more. Then you will be understand it better. When you have more anticipation of nervous tissue, nervous system, then you will be able to understand it, what is segmental and what is non-segmental. Now, this is I'm starting with making of a brachial plexus. So now I have these columns and these rows. There I have roots, trunks, divisions, cords and nerves. This is how the brachial plexus is making. And down I'll put the locations where roots are. They are present in paravertebral region. Paravertebral means just next to the vertebrae. Trunks are located, so we said that the ventral rami participate of each spinal nerve. Are you fine? Why are you pushing his shoulder?
I guess I was guessing
Don't do it. He's your friend, respect him. So C5, 6, 7, 8, T1. They all contribute in making of my brachial plexus. Sometimes C4 contribute. We call it a prefix type of brachial plexus. Sometimes T2 contribute. We call it postfix type of brachial plexus. So we have a prefix type, we have postfix type. Remember, all of them are normal. There is no problem with any of these situations. Clear? But normally, a brachial plexus is a product of from C5 to T1. All these ventral rami, they contribute in making that. So now what is happening? C5 and C6, they become friends. C7, there is nobody with him. And C8 and T1, again, they are friends. Yeah, Badri. Huh? With me, if you say the truth, I have no problem. No matter whatsoever reason. And I have no problem even if you come late. So my C5 and C6, they blend together. C7 is alone, and C8 and T1, they blend together. This is happening in the paravertebral region. After that, they reach to interscleni. What is interscleni? I have a group of muscles in the neck. They are known as sclenii. Anterior splenius, middle splenius and posterior splenius. So 3 muscles. Between anterior and middle splenius muscle, I have these nerve fibers. They are coming forward. So here, C5 and C6, they are friend together. They are coming as superior trunk. 7 has no friend, coming as middle trunk. And 8 and T1 coming as inferior trunk. So I have 3 trunks. Is that right? Why I call it superior? Because it's superior in position. And why is inferior? Because it is inferior. Yeah.
So they are emerging from what?
His question is, you said about 3 muscles. And they are emerging from what? We are not doing your neck region here. Only I mentioned between anterior splenius and middle splenius, these fibers, they are crossing forward. That's it.
How can we benefit?
Huh?
If we don't know these muscles, how can we benefit?
Muhammad, the final benefit will become once you will be certified as a doctor. This is the process of learning. Wait. Should I start teaching you the head and neck thing? Is my favorite region. You want it? I can start. Everything. When a woman gets pregnant, A baby is being delivered just after 1 minute, after conceiving, or it takes 9 months. So give yourself time. I'm saying 10 months. Wait. If someone born early is a premature birth, and that is usually die off. So these muscles are here, and they are coming in through these muscles. So there I draw a picture for that muscle. Now I have some babies, some branches. My C5 gives dorsal scapular nerve. Now dorsal scapular nerve, you may ask me so many things. I said it supplies rhomboids, but levator scapulae, the fibers of C5 which supplies levator scapulae, they are not contributing in formation of brachial plexus. So levator scapulae muscle is innervated by C3, 4 and 5. They are not innervated by purely C5. And those fibers of C5 which goes to the levator scapulae, they are not taking part in making brachial plexus. There are so many fibers of this C5. Is that clear? So this is the first branch. From where? From the roots. I have my second branch from 5, 6 and 7, and this is my long thoracic nerve. And it goes and supplies serratus anterior muscle. We talk about it in detail, and I hope you'll be knowing about it in detail. Now if you ask me which root values you need to remember, you need to remember this, not really this. Got it? Not at all. Don't say not at all. The question was how many of them we need to remember. I said before the major and main nerves which are involved in some very functional values, their damages cause significant problems. Like this is there. I'm not saying ignore it, but if you know it, it's good. If you don't know it, it's fine. Clear? First your focus should be the major primary structures. Once you have time, you can build on that. Sky is the limit. So from the roots, we have 2 branches. Now from the trunks, what do we have? We have suprascapular nerve. It supplies supra and infraspinatus. Now we enter a region which is a subclavian region, where subclavian artery lives. And that is where these trunks become divisions. So it means now these trunks, they are further dividing. You remember in my previous slide, I show you these ventral rami, they become one and then they divide. So this is the area of divisions. So each trunk divides into anterior and posterior, anterior and posterior, anterior and posterior. So these, morning, the superior trunk, middle trunk, inferior trunk, they divide into anterior and posterior. So anterior division of, anterior division of superior, anterior division of middle. So there you are looking at anterior and there you are looking at posterior. Anterior of superior, posterior of superior. So anterior of this and anterior of this, they are friend now. Posterior of this, posterior of the middle and posterior of the inferior, they all are friends. And now who's left alone? Anterior of inferior has no friend. Got it? So now I have 1, 2 and 3. And who are they? The cords. There are no specific branch which emerge from the divisions. So I have cords, lateral, medial and posterior. Got it? Now can you see that? How is the transition from the ventral rami of the roots? They were making trunks, superior, middle and inferior. These trunks, they divide into anterior and posterior. Now these anterior and posterior, they further join and they are giving us the cords. We cut the axilla at the cord level and there we saw that what is happening. Right? Why we call them lateral, why we call them medial and why we call them posterior, there is a logic and there is a reason behind. That we need to discuss. That we need to look at. Is it clear? Any question so far? Anything which is bothering you? Yes?
So all of these nerves are ventral, like
everything, the mother is ventral. Finish.
dorsal roots don't make sense.
Look, dorsal is father, ventral is mother. So who gave birth? Who gave birth? Mother. Tell me any father giving birth? Not yet. Is it clear?
Soon, the sky is the limit.
Yeah, never know. Muhammad will do a research on stem cell and he'll bring up some fathers who will give birth. Fine, Muhammad.
Why especially Muhammad?
We will do it.
Because Muhammad has started this discussion. No, I'm just kidding. Relax. Because I like you, that's why I mentioned you. But stop playing with your mobile. Doesn't mean,
Take a picture of this.
you know. It's on the Moodle. So you didn't check on your Moodle?
I checked I couldn't find the last.
You didn't find this one?
No,
It's all there.
I did not find it. That's what
Khalas. Shh. So guys, are you done? Finish? Good. So now I have lateral, medial and posterior chords. And now from the lateral chords, I have some branch. We know it about this branch. That is my lateral pectoral nerve who supplies both pec major and minor. From the medial cord I have medial pectoral nerve which supplies both. Now I have some cutaneous branches for the arm and for the forearm. From where? Medial cord. So can I call it medial cutaneous nerve of the arm and medial cutaneous nerve of the forearm?
Since you pregnant, of course.
Clear?
You haven't told us what's the reason behind calling them medial, posterior, and lateral.
Sabr, show you.
Again, the last information for the cutaneous.
Say it again.
You want the information about the cutaneous nerve.
Shh. Mohammed, khalas. So this medial cord gives me two cutaneous branches. Cutaneous word means something who supplies the skin. So one cutaneous nerve for the arm, skin of the arm, one cutaneous nerve for the skin of the forearm. Got it?
The medial aspect.
Yeah, obviously medial aspect. Now from the posterior cord, I have somebody. Number one, upper subscapular nerve for subscapularis muscle. Lower subscapular nerve for teres major. And in between, thoracodorsal for latissimus dorsi. So posterior cord gives all these branches. Is it clear? So we are not bothered for their root values. We are bothered for root value of only long thoracic so far. And next are coming up where we need it. Is it clear so far?
Yes.
Shh. Now in the brachial region, guys, this was the roots. Paravertebral. In the muscles, intersclenia region. Then in the clavicle, subclavian region. In the axillary region. Now this is the brachium. This is antibrachium. Everything is brachial here. Everything is, we will not call it antibrachial, we give it a separate names. So, my lateral cord continues as musculocutaneous nerve. Lateral cord becomes musculocutaneous nerve. And there you need to know this. What is this? And it supplies where? Anterior arm, skin, anterior and lateral forearm. So this is the area where does it supply. All the muscles which lives here. Your biceps, both heads, never say triceps. Biceps, coracobrachialis and brachialis. My medial cord continues as ulnar nerve and it supplies little bit portions. Clear? And now posterior cord. It gives a branch. It continues as radial nerve, but before becoming radial nerve, it gives a branch and that goes to the back through this window and I call it axillary nerve. So you need to be good with the root values of musculocutaneous, radial, axillary, ulnar and long thoracic. And there is one more which is very important, is yet to come. Now from my lateral cord, from my medial cord, I have two roots. These two roots blend together and gives us the median nerve. Again, for you. From the lateral cord, I have lateral root. From the medial cord, I have medial root. These two roots join to form an M. Can you see an M? Can you see an M? On the cadaver, when you'll go and you want to see this brachial plexus tomorrow inshallah, they will be showing you an M. This is the only thing which from where you can figure out who's what. If you cannot figure out where is the M, because roots are not visible there, you cannot figure out what is happening. Because after identifying this M thing, then you can establish who's lateral, who's medial, who's posterior. And then you can figure out what is happening, how you are naming them. Is it clear? Yes. Any question? So this was the graphical presentation of the brachial plexus. Now, answering your question, why we call it lateral cord, why we call it medial cord, why we call it posterior cord. This axillary artery, this one is lateral to it, this one is medial to it, and this one is behind it. So we call it posterior cord, we call it lateral cord, and we call it medial cord. You got the answer? Thank you.
So why is that window where the axillary nerve comes in?
It shows that axillary nerve is going on the back, so it is piercing, it's coming here, supplying the deltoid part. Clear? So now we will build up again the brachial plexus, but according to regions on the body. So now we know this is scalenus medius muscle, and these are my nerves. I'm making from C3 onwards. I'm not talking from C5. So ventral rami of C3 to T1 spinal nerves. They are all have been shown here. Now I put scalenus anterior now. That's it. So you can see that this was the paravertebral region and this was the interscleni region, because they are sandwiched between these two muscle layers. Is that right? So this is my scalenus anterior muscle and this brown was my scalenus medius muscle. Now I have a nerve which comes from C3, 4 and 5. What is that? Sorry my dear, it's not C3, 4 and 5. Long thoracic was C5, 6 and 7. And this nerve is coming in front, anterior to the scalenus anterior muscle, and this is my phrenic nerve. This phrenic nerve is responsible to supply the diaphragm, the partition between the thoracic cavity and the abdominal cavity. And diaphragm is one of the chief muscle of respiratory movements. If someone's phrenic is cut, there will be severe difficulty in breathing and there will be a big issue. So this phrenic nerve is being dealt in more detail in our cardiopulmonary block. Yes?
But there is more nerve.
Sabar, huh?
So both the chronic nerve and the dorsal nerve of C3 before,
Phrenic nerve is C3, 4 and 5. Long thoracic nerve is, and dorsal scapular C3, 4 and 5. Both of them C3, 4 and 5. But that is different, this is different. Mohammed, what was your question?
Was answered.
He answered you?
Make sure.
It was just a question.
Your question was different, I know.
No, he actually answered it because it led to something. Basically, I was asking about the phrenic nerve. What was it contributing to? Because we need to be actually controlling whatever it is attaching to, whatever muscle it is attaching to. So he said it was the diaphragm.
Now, there is another nerve, and this one, your question, and we call it dorsal scapular nerve. Got it? Okay. See, your complaint is growing. Yeah. C3, 4 and 5. Shh. Guys, I don't want to take extra time, so just stay with me. So now we have the cords. These are my superior, middle and inferior cords. And we call them, these cords were located where? The trunks were located where? Subclavian region. And then they become the cords, lateral cord, medial cord and posterior cord. Is that clear?
Yes.
So now, this is my axillary who goes backward. and supply to the deltoid and teres minor. And this is my radial nerve who goes down, supplies the posterior compartment. Triceps is supplied by the radial. Clear? So now there is your favorite. No, not really. It's not there. It's the thoracodorsal nerve, Forlecimus dorsi. These are my suprascapular nerves. This is my musculocutaneous. Ulnar. This is what? Lateral and medial pectoral nerves. Clear? Shh.
That's the window is a hemisphere, right?
So now, guys, this is your favorite. Finally.
Yes, finally.
Here you go. So it lives laterally. It has to supply serratus anterior. It does not need to go to the back. Shh. Is it clear? Now we have the median nerve. These are the medial cutaneous nerve of the arm and forearm, a series. So can you see I draw these dotted lines? That is showing my roots. Number one is roots. Up till this part, trunks, interscleni. And this one is divisions, subclavian. Cords, axillary, fifth are branches. Perfect. Everything is clear? Now, so we are done with brachial plexus. Okay? Yesterday you had lecture with Dr. Hassan. He was talking about injuries of nerves of brachial plexus, not injuries of brachial plexus. Okay, fine. Tell me about injuries to the roots. What happens then? Sorry, my dear. Injury to the roots.
Then maybe.
My dear, there is no maybe. There is some definitely. If your nose is cut, we'll say nose is cut. We don't say ear. Maybe ear is cut. It is specific and fixed. Your chance is given.
So there is like a gunshot. They shot knife.
Whatsoever, there is a cut.
Yeah.
Huh.
There will be a weakness in the controlling muscles.
No. So, injury to the root. Obviously, when any nerve is cut, the affected part will be paralyzed. If it is partially cut, there will be pain. If it's partially cut, there will be numbness, paresthesia, anesthesia. This is the commonest manifestation. But my question was, if there is an injury to the roots, what is the condition where there is an injury to the roots? Because he was trying to say abductional palsy. Am I right? Or you might say Klumpke's. These are not injuries to the roots. Correct? So we need to learn about injuries to the brachial plexus. Wait for that. So now I'll be building on axillary artery. It's very simple. We have right side brachiocephalic artery, which gives right common carotid and right subclavian. Now, this right subclavian, can we call it here subclavian? No. Can we call it here subclavian? No. Why we change its name?
Region.
So what, is there any landmark with us?
Sure. There is the first rib. First rib. And the pectoral is mine. Pectoral is there is mine.
And then upper limb, then you'll bring muscle of lower limb. My dear, give a specific answer.
Can I say that?
Hold on. The answer is like that. What is the blood supply of this digit? Heart. Nobody can change the answer. Yes, you are right. What is the nerve supply of this muscle? Brain. Can you challenge it? Never.
So when the subclavian across the first rib, we call it axillary. When it across the teres major.
Perfect. Give him a big hand. That's called the answer, and that answer deserves full marks. This is what is needed. So you need to be specific. When subclavian artery crosses the outer border of the first rib and it crosses the lower limit of teres major, in this distance we call it axillary artery. Beyond that part, beyond teres major, we call it brachial artery. When it reaches to the cubital fossa, we call it radial and ulnar artery. And then when it goes down, we name it differently. So it has certain specific landmarks. So now this is my brachiocephalic artery, this is my right common carotid, this is my right subclavian artery. Is that clear so far with everybody? There I have some branches from subclavian. We are not focused. We need to talk about these branches when we'll be dealing in the region of cardiopulmonary. So let's ignore it. Now, axillary artery. We know what is the extent of the axillary artery. There is the lower limit, teres major. Right? After teres major, we'll call it brachial artery. Is that right? And up till here we call it axillary artery. Why we call it axillary artery? Because it lives in the region of the axilla. So now, pectoralis minor is the one who divides it. Pectoralis minor is the one who divides. Actually does not cut this artery. We have so many muscles in our body who divides different major arteries. Do you know the other ones who are the one who doing it?
Everything that I studied before in my book.
No, I'm asking you. Do you studied it before? Which muscle divides the maxillary artery?
Which muscle divides the axillary?
Maxillary.
Maxillary?
Yes. Which muscle divides the subclavian artery?
Subclavian, pectoralis minor. No?
Then who divides the axillary? So, remember now, we are dealing upper limb. Upper limb we had axillary artery, we had brachial artery, and down. So, axillary artery is divided by pectoralis minor. When we'll be doing head and neck, we'll be talking about that. When we'll be doing cardiopulmonary, we'll be talking about that. So we have to be with the upper limb. So stay with the region. Stay within the block. So my axillary artery is crossed by this muscle. So for our convenience of learning, that has to do nothing with the functionality. For our convenience of learning, we call it first part. Under this muscle, we call it second part. And then we have third part. First part give one branch, second part give two branches, third part give three branches. Now after that it's all about memorization. First part gives superior thoracic artery. Second part gives thoracoacromial and lateral thoracic artery. And third part gives anterior posterior circumflex humeral arteries, and the third one is subscapular artery. Is that clear? So axillary artery begins at the outer, what you need to remember out of this slide, axillary artery begins at the outer border of the first rib. It ends at the lower limit of teres major. On its way, it is divided by crossing of pectoralis minor into three parts. First part gives me superior thoracic artery, second part gives me thoracoacromial and lateral thoracic artery, and third part gives me anterior circumflex humeral, posterior circumflex humeral, and it gives me subscapular artery. Is that clear? So you need to know this much from axillary artery. If you know this much, enough. We are not focused if you are able to say that thoracoacromial artery has a pectoral branch, acromial branch, clavicular branch, deltoid branch, and how they supply, how they pierce clavipectoral fascia, what is happening. These are so many details. These are not required at the moment. Yusuf, can you tell me the branches of thoracoacromial artery? You don't know. You can see it here. What I said about them. My dear, your mental and physical presence is always required. You have a question, ask me. You are busy with him, I said something important, but you are busy with some other activity. Anyway, work on that. So now, after finishing that, now we'll be starting with the injuries. Injuries, we categorize it, we classify it into injuries to the upper part of the plexus and injuries to the lower part of the plexus. Right? So now, injuries to the upper part of the plexus, we have certain other factors, and these are the regions. When we talk in terms of regions of the, what are the regions? Roots, trunks, divisions, cords, and branches. So you have done the injuries to the branches. You have not done injuries to the roots, injuries to the trunks, injuries to the cords, and injuries to the divisions. So now let's start with what happened here. Brachial plexus. Somebody fell down. Because your patient will not come to you, doctor, can you tell me what are the names of branches from lateral cord? You will not find someone. Someone will come to you, doctor, I cannot move this, I cannot do this, I have pain here, I have pain there. And you are the one who has to figure out what has gone wrong. Somebody fell down during a horse ride. Now, there is an impact of injury here. Now, injury to the upper part of the plexus. And that's known as abduction. Someone falling down. When he falls down, the shoulder and the neck, there is a stretch in between. So there is a trauma here. Upper part of the plexus. So upper part, what is upper part? C5 and C6. It's not specific to the root, to the trunk, to the division, to the cord. It's just said upper part. One situation. Second situation, obstructed labor. During a childbirth, baby is unable to pass out. Head is being moved in other direction. Now doctor put her hands or some instrument to correct the position of the, because we are all born, those who think they are born normally, their head came first and their legs came last. This is a normal way of delivery. So to correct it, and then you pull out. When you are pulling out, you are holding only the head. And then someone who is ignorant may cause a damage to the upper part of the plexus. Both of them will have the similar index. We call it abduction palsy. And now what is ab? So in this brachial plexus, the upper part has a place that is known as the Erb's point. So within this green circle, this is the Erb's point. So this part is being damaged.
Which is C5 and C6?
Part of C5 and C6 damage at this particular point. And this point is given the name of Erb's point. Erb's point. That is the specific name. As an outcome, this is one mechanism, other I had explained to you. The hand of the person will go like this. So waiter tip. And these babies who are born, they cannot move their hand. And their hand will be in this typical posture. You can say that he has an Erb's, like you, then you ask, was there any problem during the childbirth? And then you can reveal the whole story. So this one is waiter tip hand. Why we call it waiter tip hand? In old days, in Barrett era, the waiters were not that blunt. They cannot come, where is my tip? They were just standing quietly, and their hand goes like this. So you give money, it goes in their pocket. With respect, nobody knows. This is a proper way of giving and taking the tip. That's why it's given a name of waiter tip hand. This is a classic, no matter childbirth injury or when you fall on your shoulder. This can happen. This is the upper part of the plexus. So this is the detailing of it. Now the lower part, we call it klumki. When you are falling down, suddenly you get hold of something. You think you are saved. Yes, you are saved, but still you had a problem. There is a big stretch here. One. Second, some kids are naughty. During their childbirth, they push their hand out first. So hand is been out. Now doctor is in big trouble. So if she pull, by mistake, she pulls the hand, there is a stretch here. Stretch at this level. And that causes injury to the lower part. What is lower part? C8 and T1. So where in the plexus? This is the lower part. And we call it, another name for that, Klumpke's palsy. And outcome is the hand goes like this, and that's called a claw hand. Is that clear? So these are injuries which are occurring to the main plexus. Upper part and lower part. But still, we are not able to describe the other parts. So now we have another term here, very commonly used term, thoracic outlet syndrome. What is thoracic outlet? This upper part in our thoracic cavity, this is the inlet, this is the outlet, and this is the inlet. Inlet of the thorax and outlet of the thorax. Here we have clavicle, rib, first rib. So through this, so many this neurovascular bundle, nerves and arteries and vein, they passes. They passes out because of any problems in these structures, because of having an extra rib in this area. There are pressures, and remember, nerve does not require 20 tons of pressure. Nerves require a pressure. Can I peel a little bit? If this much size of thing, can you see that size? If this much size of thing is been sitting on a nerve, it will cause significant pain and pressure and everything. So you don't need kilos of pressure, weight. A fine little thing can cause serious problems. So now we will reveal it in thoracic outlet syndrome. If the nerves are involved, what can happen? Pain in the extremity, and second is extremity is numb. So there is less sensation. Vascular involvement, arterial involvement, extremity has, like you can feel that your hand is there but it's almost sleeping. Or other fact, like glove type of distribution, like this much, my 3 fingers are sleeping all the day. What went wrong? So it means there is some arterial compression occurring at the thoracic outlet level. If the veins are even involved, then we had there is a swelling here. This hand goes like, what happened? Why is it swollen? Nothing has bitten here. So now, who causes it? There is a series of syndromes, and we'll reveal these syndromes in our next slides. Now, this guy has something wrong. Can you see that? Where is what is wrong? The pain radiates from the neck and is so severe. Look how muscular is he. So this guy has a severe pain. This guy has severe pain. So what is the cause and where is the problem? So we have to locate it. To locate it, there is an injury to the root of the plexus, paravertebral region. This is the root. You are talking extra rib is somewhere here. And this injury which is causing this, there is too much overlap. But this is injury to the root. What I was asking, if the injury is occurring to the root, now how it is occurring? We know these are the roots. How it is occurring? These are the vertebrae, cervical vertebrae. If the disc is collapsing, if the disc herniate, now intervertebral foramina becomes narrow. So nerve is being trapped here, nerve is being compressed here, and that causes significant problem. So this is occurring at the level of roots. Got it? And this condition seen most commonly, and there, who was asking me to show me intervertebral foramina? Can you see them? Let me color them for you. So these are the openings from where each spinal nerve emerges out. So this is where it is. This is another image demonstrating you different parts. So this is, the situation is a condition which is very commonly affecting us, cervical spondylosis. Cervical spondylosis, what happens? There is thinning, there is dehydration of the disc, and there is a pressure at intervertebral foramina, and that causes tingling sensation, some pain, like you have seen in this image. This is a classic of, you want to go more details, this has all been described here. Minimally what is required for you. No more further details are mandatory. Is that fine? Yeah, just 2 more minutes only. Now, if there is a problem in between the spleniae, so injury to the trunks, we know trunks are here. So what is happening? Because of some trauma, because of the muscle hypertrophy, because of some extra band, they are compressed here, and we have similar manifestation. So we need to remove these muscles, we need to repair these muscles. Third condition, costoclavicular syndrome. It goes through a narrow channel if someone has broke his clavicle. This clavicle, when it joins, there is a callus form, extra bone is formed. That causes pressure on the nerve and artery. And it may present with when there is an injury to the divisions of the plexus, and there we call it costoclavicular syndrome. Last, when you have your hand in hyperabducted situation, how you are working on top something and for prolonged hours, or you sleep on your hand. So you have severe pain when you wake up. So we call it hyperabduction syndrome. Prolonged occurs during sleep and overhead painting. But some other situation, neurovascular bundle, what pathology? If someone has enlarged lymph nodes, they cause pressure over the whole of the sheath, axillary sheath. So the artery and nerve, they go in compression. Other, someone has an abscess in the axilla, that causes severe problem. Right? So these are the outcomes. I'm ignoring these slides because we'll be dealing with them in my next presentation. So they were here just for nothing. In the last, I have a small test for you. Be ready for that. Guys, make your mobiles ready. So there is a test for you. I'll put some. What is this? Abdushne. What is this? You have done this. This is not claw. Hand of benediction. Median nerve. This is claw hand. What is this? Wrist drop. Radial nerve injury. Now be ready. I am taking your attendance.
That was full.